for it, sir?
As we said, name is Afolabi Bewaji, dentist here in the UK. And just want a brief discussion of TMJ dysfunction and myofascial pain and how we get in how we're involved in that. Next slide. Because of the time we've spent, the TMJ is like the title says, it's temporomandibular temporomandibular joint disorder. It's just to do with the joints of the lower jawbone. And it also includes the joints and all the supporting structures around it and muscles and stuff. Next slide, please. This is just it's just anatomy, which shows you exactly where the joints are. You know, it's an articulation between your lower jaw, the mandible, and the base of the skull. And when it's in health, you know, you've got that articular disc. So the joint, there's always a disc in between the base of the skull and the lower jaw, so that when you open and close, everything moves together as one. Let's go on to the next slide. Please. When the mouth opens, the articular disc, the condyle, the head of the condyle, if you look at the middle one, moves to the articular, slides forward to where the red band of muscle is, but the cartilage also, that cartilaginous disc, fibrous disc also moves with it, so that at every point of opening and closing your mouth, the disc is always between the base of the skull and the jaw and the jawbone of the mandible, the mandible itself, sorry, the condyle of the mandible. Next slide, please. Yeah, so this just shows exactly what I said. In the closed position and in the open position, you have the disc that is pulled forward so that your jawbone, the condyle of the mandible, is never in direct contact with the base of the skull. And this is what happens in health. Next slide, please. Right, so that when, like it says, it's the most used joint in the body, is used more than any other joint in the body. And we know why. We eat, we talk, we snore, everything we do is all around this joint. Next slide, please. And this is just a general thing. When things go wrong, like it says, it's in 60 to 70% of general population, they have at least one sign of this, whether it's the clicking joint or whatever. Like I said, only 5% of patients seek treatment. It's more common in women than it is in men. And usually, like we say, this condition itself is self-limiting in the sense that it can come, and it just suddenly disappears on its own. So usually the initial form of treatment is always something that's reversible in the sense that if we do something, it's something we can remove without actually causing any, causing any major changes in the patient's anatomy, in the sense that, it's reversible in the sense that if it doesn't work, we can take it back and we know we haven't caused any further damage. Next slide, please. Next slide. Yeah, so, like I said, and then it falls into the conditions. It falls into three major conditions. We talk about the myofascial pain, which is, it's common with this. It involves the muscles around the jaws. So like I said, it falls into three categories. Either the muscles, which causes pain in the muscles. There's derangement in the joint itself. It means that the disc and the condyle do not move together, or they don't move together, or there's a fracture, there's a dislocation, and then there's actually degeneration of the joint itself, which is your arthritis. There's an inflammatory degeneration of the joint itself. Next slide, please. Yeah, and because it's a complex group of things, that's why it's called a syndrome. Next slide, please. Right. So it can be caused by a different number of things. It's either it could be a dental issue. If you've got if your bite, you have a filling done and your filling or a crown or something they've put on your tooth isn't in line properly and you're hitting on it first or something, it can cause this. Another, even if you've got pain, right? If there's pain in the tooth and you're not eating properly, or you're in pain, it makes you do some funny things, which can lead to problems either in the joint and the muscles around the joint, or cause total destruction of the joint itself or the supportive tissues. There's injury, like I said, injury anywhere really can actually affect your jaw. You've got grinding the teeth, which is always linked to stress. Grinding your teeth and stuff is linked to stuff. Then you got rheumatoid arthritis, gout, and fibromyalgia that affects other parts of the body that can actually affect these joints. Luckily, it's rare, but it does happen. Injuries to the jaw itself, and then head and neck injuries. Next slide, please. So like we said, some people could have TMJ problems but have no symptoms of it, in the sense that some people we say a condition, one of the causes that we always write in the exams, in these things that we say it's idiopathic. For one reason, we don't know what has caused the problem, right? And you just have the problem for no reason whatsoever, which something, it can be linked to anything. There's an inflammation or damage to the capsules or the muscles, right? Like we said, grinding, stress, clenching or biting your lip and all that. You're doing abnormal activities, and that causes abnormal movements in the joint. It can cause problems. You've also got we talked about parafunctional activities. Basically, there are things we do, especially when, I'll give an example. Exercises, when you're straining and you're doing that, unfortunately, you cannot actually, I don't know anyone who could lift a heavy weight without actually straining or grinding their teeth. When we do that, we put pressure on the joint and can cause damage and stuff. And everything, anxiety, stress, like I said, emotional problems can also cause TMJ dysfunctions, because when we are stressed or we've got emotional problems and all that, we engage in funny muscle activities, which now leads to chronic pain. And it's usually, in this case, it's only the muscles that are involved. Next slide, please. Yeah. So symptoms, like we said, it's that you'll have pain around the jaws or the cheek or the ears. The reason the ears might be involved is because the external ear and the joint have the same nerve supply, the trigeminal nerve, that supplies sensory nerve to them, and because you're straining, the pain can actually involve the muscles of the neck and the shoulders as well. Because when we strain, we're unconsciously constricting and whatever in all these movements. In severe cases, yes, there's difficulty in opening one's mouth. You can't chew properly. And at times, patients have come in where they've actually dislocated the jaw in such a way that they've now dislocated the jaw because the disc is now wedged in front of the condyle itself, and it stops it from closing, and they have to do some funny jaw movements to manipulate their jaws back into position and stuff. So, that can happen. There's popping, like we said, there's a clicking sound when you bite. You can get headaches and stuff as well, and then pain around the muscles. Next slide, please. Right, okay. Like we said, we've talked about this clicking of the jaws, popping of the jaws, grinding, limited mouth opening, and all that. Okay. Treatment. Now, usually, like I said, treatment is usually, like we've said, treatment is usually, because it's a self-limiting disorder, in the sense that in most cases, it sorts itself out. The initial line of treatment is always something that's reversible, something that if we try and it's not working, you can easily stop, remove, stop the treatment, and you haven't left any permanent damage behind. And that's the key thing about it. So usually when they come in, simple analgesics are painkillers. They say painkillers, and it's more the anti-inflammatories that really help, because it's more of an inflammation. Even when you strain the muscle, it's inflammation. There's pain, you stretch the stuff, you've broken fibers, there's an inflammatory reaction going on, which whatever the chemicals that are reduced, stimulate the pain nerve endings and all. So you want to bring the swelling and the inflammation down. And that's why we usually advocate, the painkillers that help. Soft diets, you say soft food in the sense that the softer the food, the less muscle activity you're doing, and the more you're resting the muscles and they can recover. I describe it to patients like this, especially when you now find out that there's pain in the muscle. It's almost as if you're going on a run. You've gone on a run, you're running, and when you run, after a while, your muscles start to ache because of lactic acid buildup in them, which causes inflammation and all that. And at some point, you stop. And once you give everything time to rest, it'll, the body has a way of healing itself. And that's why we say soft tissue, the less stress you put on the joints and the muscles, it'll recover, it'll repair itself. Avoid chewing gum, like we said. Cut all foods, when you eat, like we say, use a small spoon. When you're eating rice, don't hit the spoon up, but little bits and all that, so that you don't open your mouth. Usually because with TMJ, usually it starts, you find that most patients, even before pain comes, they hear the clicking. They know how wide they have to open and before they hear the click. So usually what you tell them is try and avoid opening wide enough to hear the click, because there are fibers and ligaments that stabilize the joints. And every time you hear the click, you're breaking all those fibers that are holding things together, and the healing process is starting all over again. So usually what you encourage patients to do is, cut food into small pieces. If you are going to have an apple, don't bite into it, but chop it into bits so that you put little bits in your mouth, and then you just chew with that, so that all the immature fibers that are being laid down to repair, to stabilize the joint, will be given time to mature and strengthen properly to help repair the joints. Avoid clenching your jaws, avoid opening your mouth wide. If you know how wide you open before you hear the click, avoid opening that wide. Even when you want to yawn, what we say is, stifle it, put your hand under your chin and try and stifle your yawn when you see it coming. You just avoid opening too wide so that you can give the whole thing time to rest and all. I know painkillers, paracetamol is there. It will help with pain, but it has no anti-inflammatory effects. So, and that's just the disadvantage with that one. Other long-term things, we can give mouth guards, right? The injections, we can inject steroids into the joints. Surgery, right? That's a 50-50 thing. That's such a funny, delicate joint, we try and avoid that as much as possible, because, it's a 50-50 chance whether the surgery itself would help. Some people get some benefit from it. especially if it's a fracture, you can go in there and whatever. But at times, even if the condyle is fractured inside the joint, at times we don't even bother going in there if it's something the patient can live with and the patient can adapt it. We don't bother even going into the capsule to reduce the fracture and stuff. Like I said, dentists can get involved, psychologists can get involved, especially stress and whatever. I found out that stress is a key thing. It's a key thing. There's a patient I had who, she was a carer for her husband. She was moving house, and her mom was diagnosed with cancer. So she was dealing with all this. And then obviously within a 2-week period, she came out and she had pain in the muscles. If we go to the next slide, because we're going to the myocardial pain, myofascial thing, and she had pain in those muscles. And you got 5 muscles of mastication. You've got the 5 muscles you've got temporalis, you've got your medial and lateral pterygoids, you've got muscles, but muscles under there, muscles on your cheek, muscles on your temple, which is what's responsible for the headaches and all. Any of those muscles that are involved in chewing, because these muscles are involved, they are the muscles that are actually involved in closing the jaw. And these are the muscles and basically this lady, with all the stress she was going through, thought, she had discovered, she too was getting cancer and all that. She had been to a GP and they gave her they gave her some medication and all that, but nothing was helping. And in terms of treatment, one of the things I did mention about is, I didn't actually talk about, is talking. You find out that talking to the patients and explaining exactly what is going on makes a massive difference. It makes a huge difference. And we can give, especially with patients that grind their teeth, we can give them mouth guards to wear. But, and that does, the idea of that one, it props, what the mouth guard does, it props your mouth open. Usually when we're at rest, if you all do this actually, when we're at rest and there's no muscle activities in your muscles of mastication, right? The muscles you used to chew, there's a gap between your top and bottom teeth, right? What I want you to do is now just close your mouth. Just bring your teeth together. And don't clench, just bring your teeth together and hold it there.
Hello, hi, doctor.
Yeah.
I'm not sure how many people can actually see you right now because I can't actually see you.
Yeah.
So it might be that after we finish the presentation, we can do that.
We can do that.
Okay, I'll continue recording.
So it just, okay. So it said myofascial pain. So this is the muscular aspect of the TMJ problem. And it's just chronic pain affecting the muscles of the jaw. Next slide. Okay, like we said, it's pain that's deep and is located within the muscles. You find out the affected muscles are strained or stretched, right? And it gets worse if nothing is done. And the pain can really, really be intense. And like I said, it can disturb sleep. It can cause mood or sleep disturbances. Next slide, please. Treatment. Like I said, it's a multiple pronged thing. First of all, like we said, because there's an inflammation in the muscle and there's inflammation and pain in the muscles of mastication, you want to give something to stop the pain and reduce the inflammation. Like I said, you've got your non-steroidal anti-inflammatory like your ibuprofen, your your Nurofen and all. The acetaminophen, that's paracetamol. That would, like I said, that would help with pain, but that would not help with the inflammation because it's got no anti-inflammatory properties. Yes, there are other pain relief such as lidocaine and all these patches that can be given as well. We don't normally use them. It's not something we use here. Muscle relaxants, that's your benzodiazepines, which is your like your diazepams and stuff. We used to use that, but that's something we don't use here. What that has been substituted with are your antidepressants. So what they found out that just like how, and this is one of the things we explain to patients, that just like how they found 100 things aspirin can do is useful for, because aspirin was developed as a painkiller and stuff, and it's hardly ever used as a painkiller anymore. It's all the other properties. It's anti-clotting factors and everything is used for so many. They found that aspirin is good for 100 different things now. And the same thing with your tricyclic antidepressants. They found out that they are very good to treat chronic pain in very small doses. So usually your patients who are depressed, and an example of these are your nortriptylines, your amitriptylines, and they found out that in those people might be given 75 milligrams 2 or 3 times a day to help treat depression. But they found out that in very low doses, 10 milligrams at night, and at times we find out that even some patients find that a bit too much because it completely leaves them spaced out and ruins their day. We say 10 milligrams every other night. It's very good for chronic pain in very low doses. And that is why it's used to treat it. It's used just the initial phase, just to get them over that initial acute phase of the infection if your normal painkillers do not work. And then you can now go on to, and once you've done that, and you can now go on to other things. And it talks about the Botox injections as well, which basically, like you said, what it does is it just stops, and what that does is it just stops propagation of the signals down the nerve fiber. So as long as it's there, however long it lasts, it will stop pain signals being sent down that nerve, so the patient will not be in any pain. Next slide. Yeah. So like I said, like we said, it involves both the dent with things like this. It involves the dentist, especially if it's you can get psychiatrists involved especially when it's got to do with stress, when it's stress induced and all. Yes, it can be quite this, and this is just how we manage it in from the dental point of view, because it can affect virtually every muscle in the body. But when it's common amongst in facial with the muscles around the jaw, and this is how we tend to. This is how we deal. It's quite common. Like I said, it's really stress induced. I cannot stress that enough, and I think that's probably why I wanted to talk about it, because of our busy, stressful lives as we run around chasing everything. To bear that in mind, that even like I said, if you chew too much gum, if you're chewing gum all the time, and I guess with your football managers, you find out that's a lot of things that they do. Next slide, please. That's a lot of things that they do. They chew, and what they're trying to do is relieve the stress. I guess if they were not chewing gum, they would grind in their teeth, and I guess it's easier for them to chew gum while the match is going on and all that. But it's just that when you do that, you're stressing, you're putting, the muscles are doing a lot more than they should. And the forces that we're using to eat and chew, they're really, really strong forces. They're heavy forces, which we probably don't realize, but they're real heavy forces. And that's why we get this damage. I've picked out the myofascial pain because it's quite common and it's quite debilitating. And I want to stress it enough. Talking to the patient and explaining exactly what's going on with them is actually a big help. And it's very important and stuff. Usually patients come in and, you want to give them 20, you want to, you do your checkup in 10, 15 minutes and you want to kick them out. But you find out when a patient comes in with TMJ stuff, you're probably spending about 30 minutes with them, just trying to explain the problem, because that once they understand what's going on, first line of treatment, and once they understand, they can help them get better. Thank you. I hope I've not rushed through the whole thing. Sorry, I apologize again for the problem, and I'm happy to say the computer is now working.
Okay.